All right. So my job during this lecture is actually to introduce you to evidence-based clinical practice. Evidence-based clinical practice is something that we practice almost every day, not in a hospital setting, not in a clinic setting. We actually practice evidence-based almost every day in our lives, and I'll show you proofs. But the objectives of this lecture is first of all to understand this concept, and then to be able to do critical appraisal. And you hear this all the time. Today, or these 3 days are the 3 days on to learn how to do critical appraisal. Also, to be able to formulate a study question. You might end up being a researcher, or you may wanna ask a sensible question. So you want to know what are the qualities on how to ask a question. And eventually, if you're going to be able to get these qualities, you'll also be able to stay updated with the literature. Because, you're going to be able to choose which study to learn from. Okay? So, because you're going to differentiate. You say, this is garbage research. I'm not going to follow it. This is good research. I'll follow the recommendations. I'll change my practice, or I'm not going to change my practice accordingly. So these are the qualities. You see a study, and you say, okay, I'm an orthopod. I'm an orthopedic surgeon. And the study says this maneuver is better than the other maneuver. But the study has a lot of bias, or it has a very low quality in terms of methodology. Your job is to be a judge. If this study has a bias or poor methodology, you may not follow their recommendations, because garbage in, garbage out. You don't follow it. Okay? And in every paper, and I've been in your position, and I remember being postgrad year 1 and 2 and 3, and there is this tendency to avoid the methods section. صح ولا لا? And once you see a study, you look up the background, because it's clinical information. Oh, this has been done for this, and the study shows this, and the study will investigate so and so. This is the background. And there is methods. But what we tend to do, intentionally or non-intentionally, is to just skip the methods, go to the results. Or sometimes you just go to the conclusions. ريحنا يا عمي. What's the zibda? We don't want to know what happened in between. Our job today is to tell you that this is the most important part of the study, methods. Because methods tells you whether this study was built on a good infrastructure, or it was very hazy structure. So you probably don't want to follow the results of that study. Okay? But I know this might be an intimidating information to cover in 3 days. Don't panic. Be cool. We'll take you through the story. We build up a little bit of experience on how to take you through gaining knowledge in clinical epidemiology. So there's no way that we're going to make you panic. We want you to stay calm, take you through the process gradually. So we're going to cover principles, and we're going to also cover main types of studies during this hour. I'm a simple guy. I need to make it even simpler. I'm a physician at the end of the day. So how do we explain epidemiology, or how do you explain research? There is the contents of research, or let's say the organs of research, and there is how those organs are actually working. So there's anatomy, and there's what? Physiology. So anatomy of research and physiology of research. So what is the anatomy? Anatomy usually is like when we have a focus group, let's say a table of 4 researchers, they sit down together and then they say, I would like to see the effect of this medication on this disease. So they put up a protocol to answer their study. The protocol. Protocol has so many things to cover, but they're very simple and they're very intuitive. They're very sensible. They make sense. First of all, you have to make sure that you have a very good, clear question. And we'll go through this with examples as well. A question that makes sense will have sensible answers. So what to address is the research question. This is how they start. I would like to see the effect of this medication on this disease. Okay, so let's break it down a little bit. And before even seeing the contents of the question, let's see what's been done in the past. So what's the background? Okay, so previous research have looked at this medication in different sets of diseases, and it was found that it was effective. So people have said that in the past. Or this medication was tried on this specific disease, but in a different setting. Let's say in an ICU setting. But I want to see it if it works on my medical ward setting. So there is something that's been done in the past and might or might not be significant to you. So you have to cover what's been done in the past as a researcher. Let's think as a clinician, not researchers, but with a research theme. Oops, sorry. You need to know what's been done in the past and what the significance of that, so you would justify why your question is important. As simple as that. Hello? So far is good? We know that. We see that all the time when we read papers. We see the background section, what's been done in the past. And then you decide about the design of the study. Over how long? What would be the approach? Or in another way, what would be the type of the study or the structure of the study? You want to know, or you want to make sure when you read a study or when a research focus group are sitting together, let's say, I want to see the effect of this medication on this disease prospectively and in the future, or retrospectively, what's been done in the past. So they have to make their mind about how to answer that specific question. And also part of it is that who are the participants who are going to be in the study? Who are the study? We don't like to use the word subjects, but who are the people who are going to be enrolled into the study? They have to have specification, number, how we select them, what setting, ICU, health, clinics, the public. And you have to do a selection criteria and sampling design. Then you want to make sure that you identify what set of, let's say, variables. Variables. Variables means that there is something that is the effect, and there is something that is the resultant. Effect could be replaced with the word intervention or exposure. The resultant could be changed with the word outcome. Okay? And there's this annoying word in between. It's called confounding. Can anyone explain what confounding? This is the first engagement of audience. So can anyone identify what a confounder means? I know you guys know. This first question, I might look at, and it might be embarrassing to say a wrong answer. I'll give you that. So I'm going to repeat that answer because it sounds terrific. Okay? Just speak out loud. Hey, good. Tell me. A factor that might affect the outcome, but it's not of our interest. This might be partially right, but we may argue that there might be also another name for that definition. But your colleague in here was saying that there is this variable that is related to the exposure or a predictor and the outcome. So the predictor and the outcome confounding would be between the predictor and the outcome. And I'll ask you a question and you'll tell me what the confounder is. Coffee, cheers, causes heart disease. Right or wrong? What's the confounding? Coffee causes heart disease. This is true. It's been approved by research, but there's a confounder. Shinu, what's the confounding? Smoking. So coffee drinkers smoke more. Yeah, it might be true. Those who drink coffee, or most of the smokers, they drink coffee. So if you study the relationship between coffee and heart disease, you find that there is more coffee, more heart disease. But it's not the coffee itself. Because if you take out smoking, you're not going to find this relationship. As a matter of fact, coffee may protect against cardiovascular diseases. But coffee, with the influence of smoking, because smokers drink coffee, or coffee drinkers usually smoke, or most of them smoke. Anyways, so smoking is the confounder for heart disease. So it might be something that, not that we're not interested in, but there might be something that's hidden, that's causing this relationship, and we have to identify it. Okay? Do you all get what confounding is now? Confounding is a hidden element, hidden player in the equation. Okay. And the last thing is statistical issues, and this needs the help of biostatistician. You're not requested to acquire these skills, but there's a hypothesis, there's a sample size judgment on how to get or how to calculate the sample size, and there is a way to analyze the data. So how large and how to be analyzed, kind of thing. So researchers sit together and they decide, and there should be a biostatistician with them, and then they decide how to do the statistical part of the research. So this is the anatomy of research. This is how research is formed of. Let's start with the first one, research question. Research question should have the objectives and the uncertainties, should answer the uncertainties. You should have a very good objective to the question. So the question is, or the uncertainty is the level of residence in clinical epidemiology, or the knowledge of residence in clinical epidemiology. When you do a test and you find out that there is less knowledge, so we need to set a workshop with objectives. Okay? So the research question should really, before analyzing the research question, before looking up the research question, it should pass a very simple test. The simple test is, so what? صح? Sometimes you get this, so what? Yeah, a research question, very good, مش عارف, but if you answer it, is it going to change your practice? Is it going to influence the health knowledge? Is it going to change the guidelines? So what, or خير test, is a very important critical step in formulating a question. Question should make sense and should be important. To make it more formalized, to formally do the simple خير test, we should go through an acronym, and we called it FINER. And I'll give you the first one of this acronym. And these are the qualities of the question. So the question should be feasible, FINER, feasible. So there should be feasibility. We can answer the question. We shouldn't ask a question that cannot be answered. We shouldn't study a question that cannot be answered. But the question should be feasible to be answered. So there's feasibility to answer it. Okay, so I need your help with filling the other parts of the acronym. So I would be, so what would be the question be? The question should be I. The question should be, come on. Come on, Haji. Come on. Starts with a letter I. The question should be, should the question be interesting? Ah, you guys got it. So the question should be interesting. So that should be interesting to your work. The question should be new, novel, something new. Yani, you can ask a question that's been answered in the past, but you should have an addition to what's been done in the past. But you shouldn't be asking a question that's been answered, full stop, because you're going to find the same results, mafrood. Okay, so it should be new or novel. The question should be something beyond being easy, because it should be simple. I agree with you. Can we answer non-ethical questions? So the question should be ethical. You can't answer a question about you can't answer a question with a study that says, if you force people to smoke, you can't. Right? You can't force people to smoke, right? So you can't. The question should be ethical, and the question should be beyond being reasonable. Yeah, realistic, and to your work. It should be relevant to your work. It should be related to your work. So the question should be feasible, interesting, novel, ethical, and relevant to your work. This is how you scan the question. You have a question, it should be feasible. We should be able to answer it. Otherwise, we shouldn't ask it in the first place. It should be interesting, should be novel, should be ethical, and it should be relevant. This slide is probably the slide of the workshop. You might hear the word PICO 100 times during this course or during this workshop. So PICO is how you break down the question into more than one part. So you have the P that represents population, you have the intervention. Some people exchange the intervention with something else. It's called exposure. So you can have the exposure or the intervention depending on the design of the study. We can talk about this, inshallah, during the course of the workshop. The intervention should be compared to something, could be compared to nothing. And if you do nothing, what's going to happen? And if you do something, or if you give one comparator against another comparator, so that's a comparison between two things. And there should be an outcome to the question. What are you measuring? What are you looking at in terms of outcome? Now we said in terms of predictors, there is an intervention and there is an outcome. There's also the confounder, but there is an intervention or predictor, and there is an outcome or the resultant. Okay? Some people may add the letter T at the end. They say PICOT instead of PICO, because they want to know answering the question in a time frame, over 1 month, or over 1 year, or over 10 years, depending on the study or the question itself. The question that you're formulating, you're gonna get this more and more exposed to during your small group tutorials. So don't worry, we're gonna cover that more. But PICO, if you want to take something out of this workshop, it would be how to formulate a question and how to break it down into the PICO. format, huh? Four parts. May end up destroying this or throwing away. Sorry, يعني معلش. Let's get an example. معلش رايكم? Because might be hard to just نتنظر وهذا, but let's get an example. The example is, should people eat more fish? Question. سمك زين مو زين. It's a question. It's a good question, but it's not that specific. ما يبرد الكبد. Should have in a clinical epidemiology course should be specific. Should know what do you mean by should people eat more fish. I'll give you a set of questions with more specific format. Not perfect, but better than this format. How often do Kuwaitis eat fish? So you identify the participants, and you're asking about the frequency. Hello? So you're looking at the outcome, and you're identifying the participants. So this is a little bit more specific than the one above. صح؟ إذا ما هزيتوا رؤوسكم يعني خلاص امشي. You have to, لازم تهزوا رؤوسكم. So how often, what's the frequency of Kuwaitis, we identify the participants eating fish? This is more specific than should people eat more fish? Okay? Another one, does eating fish lower the risk of cardiovascular diseases? So what's more specific in here? The outcome. Bravo alaikum. So the outcome is more specific in here. Is there a risk of mercury toxicity with fish? What's more specific in here? Outcome, safety profile. Here it's a safety profile. Here is the good profile. This is the safety profile. Is it beneficial? Is it harmful? So far it's good. Is fish oil equivalent to dietary fish? What's more specific? There is a comparison. There is the intervention, which is dietary fish, and the comparison is fish oil or vice versa. You can have both of them. Okay? So this is more specific. So at the end of the day, being more specific is much more relevant to clinical epidemiology because it really depends on the question. The answer depends on the question itself. I'm just going to switch over to types of studies. But just to simplify things for everyone, myself included, I'm very simple. I'm trying to be very simple. Design of the study in which it's either an observational study. Observational study means that the investigator has absolutely no role or no control over the environment of the study. They're just watching what's happening. So there is something that's happening, and that's when exposure happens. It's not intervention, because intervention is usually here. So when exposure happens, that's when the role of the investigator is passive. This observational study has different format, and we'll get to that, but usually the role of the researcher is passive, where they just watch and measure what's happening, versus an active clinical trial. So whenever you hear the word trial, it means that the environment is being controlled by the investigator. The investigator have the privileges or the control over who gets what, intervention versus comparator. So trial means that the researcher have an active role in the study versus just an observational study. And there is in between diagnostic tests. The diagnostic, they're very obvious. You're looking at diagnostic tests. When you break down observation and trials, and observational in the big term may also include more types of studies, but we have the cross-sectional studies and cohort, and that cohort could be retrospective or prospective, and with the trials could be randomized and non-randomized. I'll go into more details with these, but let's start with cohort. Here I'm going to try to take you through this diagram to understand the differences between studies. I'm sure that you're going to find it very intuitive, very obvious. But let's start with the cohort. What's the meaning of the cohort? Can anyone tell me what's the linguistic meaning of cohort? Cohort simply is a marching group of soldiers. Have you seen marching group of soldiers? They go in blocks, and people are watching them moving. Right? So this is a cohort, linguistically speaking, a marching group of soldiers. This is a cohort. And what happens is that the researcher will assemble a sample of patients from the population. Sample of patients comes in. بالك الواير استاذ بالك الواير ها لانه قاعد يفصل هذا and people may measure the potential predictors. What's the predictors or the exposure, and also follow the cohort over time to pick up what? To pick up what? Outcomes or outcome. صح? So what cohort happens is that people will start at one point, they have no outcome, and you watch them going in while they're receiving an exposure. There's an exposure happening to them. Sunlight, smoking, medication, oxygen, whatever, surgery. And you see over time what happens to them in terms of the outcome. Death, side effects, benefits, okay? So this is the cohort study. Cohort study, obviously, observational study. Starts with a group of people, and they move over time. Let's get into diagram fashion. I like drawings, so I'm just going to go with the diagram fashion. So let's say that we're at present time now. Present time, and this is the whole population. Okay? So this is the whole population on Earth. And there is one risk factor that increases in continuous fashion. Let's say blood sugar, for example. And blood sugar goes from 0 to indefinite. I'm not sure what the highest level is. But for researchers or for physicians, we like black and white. So, we like normal, abnormal. We always say normal, abnormal, black and white. So we'd like to draw a line. And I would draw a line somewhere in here where it says that whatever is above the line is abnormal, whatever is below the line is normal. Hello? Let's say this is abnormal, this is normal. In terms of risk factor level. تيجي؟ قاعد تصور. So above is abnormal, below is normal. And let's say that what we're going to do is that we give a label. So those who are above that level will say the risk factor is there. High blood sugar versus normal blood sugar. Risk factor is not there. Hello? And this is again at present time. And what happens is that we follow up these guys over time. We see what happens to them in the future. And the hypothesis would be is that those with the risk factor will have more disease than those without the risk factor. Does that explain what I just said in the previous slide? So you get a group of people at present, get a sample from the whole population, and from that sample you label them as having a risk factor versus not having a risk factor, with the hypothesis that this risk factor will be leading to the disease more than those who don't have a risk factor. Or those without the risk factor will be healthier. Good? نمتوا؟ تختوا؟ Okay? So this study is called a cohort study and has its own strengths or advantages. First of all, it's very powerful to assess incidence. What's the definition of incidence? I know you guys know. So picking up. Excellent. So those who get the disease while you're watching them getting exposed to a certain exposure. So the number picking up new cases. This is the incidence, صح? New cases. By statistics, and this is all coming back to you, صح? سنة سادسة, those who study in Kuwait, صح? This is by statistics. Okay. It's very helpful for potential causes, does not cause direct causality, does not tell us about direct causality, but it's very helpful in potential causes. It tells us that those who smoke may develop lung cancer after 5 years, let's say. مثلا, let's take that as or let's take those with high blood sugar will have retinopathy, eye diseases. Okay, let's take that as an answer. Why would I say helpful and not definite? They may not. And why is that? There might be confounders. There might be something else. Or the appropriate term is co-intervention, something that happened during the conduct of the study. Those high blood sugar people with retinopathy may have, let's say, high lipids as well. Okay? So it's helpful in potential causes. It's not definite, but it's very helpful. And establishes time sequence. If you know the time of the exposure and you have the outcome, you can establish a time sequence. Let's say that someone starts smoking today and after 5 years they developed colon cancer, for example. You know that the relationship between colon cancer and smoking may take up to 5 years to develop. So if someone smokes today and develops colon cancer the next day, you know that this may not be so there is a very good time sequence establishment in cohort studies. And it prevents the influence of existing outcome because you're not starting with an outcome, you're actually starting with a healthy person. That healthy person, you watch them develop an outcome. Beneficial outcome or detrimental outcome. But the cohort studies are not free of weaknesses or disadvantages. Cohort studies, yes, the causality might be there, but it's not very strong. There might be a relationship between this exposure, and we said that there might be something else as well. And there is this persistent role of confounders. We're using the same term again. There might be an exposure to something else. Okay? It's quite expensive to follow up a group of 5,000 people for 5 years. Very expensive. And there is this risk of losing some of them, drop from the study, or lost to follow-up from the study. And you don't know whether they're lost to follow-up because they're dead, or they're too healthy, or they just decided not to continue with the study. So as much as it's expensive, there's also this risk of loss to follow-up. And it's definitely not the choice for rare diseases. What would be the choice of rare disease if you want to do a study on rare disease? What would be your choice? Ya salam alaikum. Case control study. Bravo alaikum. Going retrospectively. Bravo alaikum. So you start with the disease itself because you can't study the nature of developing the disease. Let's say a disease prevalence is 1 in a million, which means that you have to get 1 million people and wait for them for I don't know how long to pick up one case. And you can imagine how expensive that is. Okay? So it's definitely not for rare diseases. And the usual question is for rare disease in the exam, rare disease is case control. خلاص. Case done deal. So let's apply this on our fish intake example. The way to answer with a study with a cohort design for the fish intake would be, and this is one example, can be done differently, but I'm just going to give you one example, is the fish intake measured at baseline and follow-up visits looking for cardiovascular diseases. So you get a cohort of people and you measure their fish intake and then you watch them and you try to pick up these new cardiovascular diseases, and you make a link between fish intake and the development of cardiovascular disease. This is a cohort design to our fish intake scenario. Okay? Any question about cohort? We'll go to the next one. And next one probably we're all familiar with because we either been involved in it or we've done it. Cross-sectional studies. Cross-sectional studies, the other term would be, question is snapshot, not Snapchat, snapshot. Right? So snapshot is for cross-sectional studies. So let's get to cross-sectional studies. Cross-sectional studies basically is all measurements done at the same time. So no one is going to be lost to follow-up, because let's say that I'm going to collect a survey from a group of 60, which are you guys, 60 people. I'm just going to give you surveys. You're going to answer them and take back the surveys. You go out, hasta la vista, khalas, the study is done. Hello? So you do all measurements at the same time. So there's no need to follow up. There are no people going to be missing because everyone got involved, and it describes the variables and their distribution. Let's say I'm asking everyone about their weight and whether or not they have thyroid disease. And let's just get that. The weight and thyroid disease. So the answer I'm gonna gain from that study would be making an association between weight and thyroid disease and seeing whether people with high weight they have more thyroid disease or vice versa. Making that would be my study. So both the predictor and the outcome are measured at the same time. صح? I'm asking about the weight and I'm asking about the thyroid disease. And I'm assuming, making the assumption or the hypothesis is that weight affects thyroid. Okay? But the causality is very difficult in this scenario. You cannot be certain about that, definitely. And the magical word for cross-sectional studies are prevalence. So what's the definition of prevalence compared to incidence? Prevalence is it really new cases? So number of cases. You do a snapshot, you just ask people about their thyroid disease, whether or not they have thyroid disease. And let's say out of the 60, 6 have thyroid disease. So I'll say in the general population, 10% are affected with thyroid disease based on this snapshot survey. Okay? Diagram. So we have our same population circle. We've drawn a line in here and in a snapshot, and just one touch, we kind of making this conclusion. Risk factor with the disease is high, no risk factor with healthy is high. Okay? So those with high weight have high disease, high thyroid. Those with low weight have no thyroid. And there will be some exceptions. Those with high weight, those with low weight have thyroid, and those with high weight have no thyroid. But the theory is weight causes thyroid disease. Okay? So that's the way we deal with it. So what would you think the strengths or the advantages of cross-sectional studies are? Easy, excellent. Fast, and less expensive. Don't like to use the word cheap. Less expensive. So fast and inexpensive. And the other thing is, you don't lose any people, right? You just throw a survey on 60 people. You get the surveys back. You have 60 surveys. Salaam alaikum. Study is done. So no loss to follow up. What would be the disadvantages? No causal relationship whatsoever. There's an association. But compared to cohort, this is zero causal relationship. You cannot make a causal relationship. So, well, what other problems are with cross-sectional study? It's not measuring. It's probably not measuring everything, but you're measuring something interested to you. What about rare diseases? Is it a good idea? Let's say that we look for mitochondrial disease in a group of 60 people. What are the chances we're going to find one? 0, because they're very rare, right? So it's not practical for rare diseases. And the other problem is excellence. So it has a relationship with time. So you don't know what happened in the past. You don't know what happened in the future. You're not studying this. You're not studying the nature of the disease. You're just studying the disease for now. So it's very good for decision makers because they want to know how many diabetics are in this room. Okay, we have 5, so 5 out of 60. نقول مثلا 8% of population have diabetes. Okay, so they make some decisions, big decisions, in terms of managing healthcare based on very fast answers. But the problems are that it's difficult to establish this causal relationship. It's not good for rare diseases, and we don't know what happened in the past, what's going to happen in the future. We're not following patients, or we're not asking them about the past. So if we go to our table for the fish intake for cross-sectional studies, we just run a survey about the predictor and the outcome. So we ask them about fish intake, and we ask participants about cardiovascular disease. And we look at the relationship between fish intake and cardiovascular diseases. Okay? Direct and indirect relation. So, am I making sense? Well, it's the usual Tuesday, or you guys are weird. Good? Okay, so hopefully I'm making sense. Stop me, please stop me if you don't understand what I'm saying. And then, we'll jump into case control. You guys know the magical word, rare diseases. But what are case controls? Case controls simply are two groups of, before case controls, just to touch on incidence and prevalence. Incidence is those who get the disease, so new cases, versus prevalence, which is people who already have the disease. Okay, so not necessarily new cases, but everyone who have the disease. Okay? So for case control, the investigators want to know the cause of rare diseases, and they usually start with a case series, a group of patients, and they want to know what the risk factors in the past are, and they usually use controls as well. So it's always, case controls are always retrospective. You're not looking at the future, you're looking at the past. You start with the outcome, and you look at the exposure predictor. Excellent. So in a diagram fashion, let's say that we have two populations, and we're choosing samples from those populations with cases and controls, sample with the disease and sample without the disease. And going backward, going retrospectively, going back to the past, and you want to see whether those with the cases have a risk factor more than those without the cases having less risk factor. Okay? Give me a rare disease and possible cause. Mesothelioma and possible cause will be asbestos exposure. Are we all familiar with this? I know there are dentistry in the room. Are we familiar with this? I usually identify dentists by their look. They're very tidy, very cravat. They're very. Sorry, guys, physicians, especially surgeons and orthopeds. I can tell who's the physician and who's a dentist just by their outlook. And I'm not a good judge, but yani, it's very obvious on the faces. So are we all familiar with mesothelioma? Mesothelioma is a cancer of the covering of the lungs called pleura. Mesothelioma is a cancer of the pleura. So there is this assumption by your colleague that asbestos exposure causes mesothelioma. So you get a group of people with mesothelioma and a group of controls without mesothelioma, and sometimes we get the controls similar to the cases in some circumstances. But anyways, the most important thing that the sample of controls do not have the disease, and we look retrospectively to their exposure with asbestos, right? So I asked the people with mesothelioma, did you get exposed to asbestos? Asbestos can be found in in the houses or in workplaces. So you ask them about their housing and their work and their job, and you ask the same thing to controls, hoping using that theory to say that mesothelioma is caused by asbestos, and the absence of asbestos will lead to healthier life, mesothelioma-free life. Okay? So this is the conclusion. But the way that we design the study is that we start with the cases and no cases and the controls, and we go retrospectively in the past and ask them. So far, so good? Okay, so obviously this has a lot of strength. And one of the important strengths is that it gives you, it's adequate for rare diseases, as we said. Also, it's adequate for delayed disease. If a disease takes 10 years to develop, you cannot obviously follow up a cohort of patients for 10 years waiting for the disease to happen. So it would be more convenient to start with the disease and then look to what happened in the past. Okay? It's fast and inexpensive, almost similar to the case control, but you have to do chart review, or you have to get patients in and interview them about the past. So it's fast and inexpensive. And you get so much information from few patients. You've got a patient with a diagnosis, and you want to make so many theories about them. So you get so much information, and it's useful for hypothesis generation. Okay, so you may use the information to design a study from a case control. And we'll get to that in our table, but let's talk about disadvantages. This is the most important disadvantage, which is missing data or recalling data. You ask people about their smoking behavior and their exposure to asbestos in our example, and they cannot recall whether their houses was made of asbestos, their AC was made of asbestos or not. Okay? So there is this risk of recall bias. And also the assumption that going to go back, assumption that these two are two different populations. This is not true. It's actually one population from which you choose cases and controls. So this assumption should be kept in mind always when we criticize case controls. We start always with one outcome. We cannot say that we're starting with, or we're looking at safety profile, beneficial outcomes, etc. We always start with the case, and the case is usually defined with an outcome, the diagnosis. Okay? And obviously we cannot get prevalence or incidence because everyone has the disease in our cases. And everyone does not have the disease in our controls. So it's 50-50, so you cannot establish prevalence and incidence in the case control design. So when you go to our table in here, in the case control, how would you expect it? Let me just go back. How would you expect case control designers? Fish intake. Those with Excellent. So you start with the outcome, and the outcome was cardiovascular disease. So you get two groups. You get the cardiovascular disease group and the no cardiovascular disease group, the healthy group. And you ask them about their fish intake habits. So this is how case control is built. All right? So you compare patients with cardiovascular and no cardiovascular disease about their fish intake behavior. All right? Now is the randomized control trial. Our goal. RCTs are simply a sample from the population where people do this magical thing of randomization. Magical thing of randomization. So people are randomized into either treatment group or intervention. And this situation, if you remember what we said, this situation, people are doing what? They have an active role. This is a trial. Randomized control trial. So the investigator have an active role into the randomization and deciding based on randomization what to be given, treatment versus placebo or treatment versus another treatment. We call it head-to-head comparison. Okay? So placebo would be the usual care, for example, plus nothing, and treatment would be the usual care plus an extra intervention. Hoping that what happens is that the intervention will cause less disease than the no intervention. No intervention will have more disease. As simple as that. This is RCT. RCT, as we said, the investigator applies the intervention. And RCT would be the best way to show causality. I need someone to defend this. Why do you think RCT is the best way to show causality? It's actually within its name. What's the problem with causality with cohort? And again, so far, cohort is the best way to demonstrate causality, yet you're not 100% sure. Because there might be confounding. And how do we kill confounding? Randomization, ya salam alaikum. I think we should end this workshop because you know everything. So if you do randomization, you kill confounding. Because if there is a confounder, it's going to be distributed into two groups equally. Sah wala la? Let's say that we assume that coffee causes heart disease, and there is this confounder of smoking that we did not know about. What's going to happen to smoking when we do randomization? It's going to be distributed equally. This is why randomization is strong. This is why randomization is the magical word in research. When you say this is randomized control trial, يعني لا تحاكيني. This is RCT. لا تتكلم رجاءً. ليش? Because randomization is this magical process of having a fair game between two groups, and the only difference between them would be what? The intervention of interest. So you have one intervention, you want to test it on one group, but you want to make sure that these two groups are separated equally or split equally. How do you do that? Randomizing them. So you do, if randomization is done appropriately, you'll make sure I'll use this just difficult sentence. If randomization is done appropriately, you'll distribute prognostic factors equally. So everything, it's going to be a fair game. Everything will be distributed equally, except for one thing, which is the intervention provided by the investigator. So it's a fair game. So this is the strength of randomization. So it's the best way to demonstrate causality. And randomization kills confounding, as I told you. It eliminates confounding. And blinding eliminates co-intervention. We'll get to that in small groups. I don't want to confuse you. You're going to start asking yourself what's blinding and what's co-intervention. But hold on to that thought for the small group. However, the disadvantage that probably this is the most expensive way to apply research. RCTs are hugely expensive. That's why people try to answer questions differently without an RCT, because RCT, you have to have a controlled environment over so many things. So that money, when money talks, people will be a little bit hesitant to go with an RCT. Otherwise, you would apply RCT everywhere. And the other thing is, what's wrong with RCT? Ethical issues. So when you ask a question, you say, oh, I'm going to answer it with RCT. There might be ethical issues to it. There are things that you cannot randomize. Surgery is one of them. General surgeons, can you show me hands? I would assume this group in here. So for surgeons, let's say that you want to do randomization into, you get two people. I'm just going to give you a hypothetical scenario. I know that this is not real life, but two people with appendicitis, you apply antibiotics on one, you do appendectomy on the other one. So, but you want to do some sort of blinding. You want to make sure that the patient does not know whether they had an appendectomy or not. So you send both of them to the OR, you open both of them. One of them you take the appendix out, the one of them you leave the appendix and you just suture back and send them back to recovery. Patient did not know whether their appendix is there or not. And you give them both, one of them antibiotics, the other one placebo. So one had the appendix out without antibiotic, the other one had antibiotic with the appendix intact. But the problem is what? What's the ethical issue in here? This is a good randomization. What's the problem? ليش؟ شنو سويت؟ Huh? You cannot play with human bodies like this, صح? You cannot just open a suture قصينا عليك ما سوينا لك عملية. You cannot do that, right? So randomization has to be ethical. That's why some of the questions cannot be answered with an RCT. And other than being expensive, the question is so narrowed. This might be a good thing. This might be a challenging thing for investigators. There might be potential harms because you're giving an intervention, assuming that it's been tested in the past and was fine. But how do you know for sure that this intervention have a very good safety profile? Unless you do an RCT. So RCTs can go either way. Can be beneficial, or can be harmful, or can have no effect. So it can be neutral, okay? And as I said, may not apply for every research question. So in the design of our fish intake, you randomly assign two groups of people to either fish or no fish, and you look for the outcome, which is cardiovascular diseases. How are we doing so far? Good? Okay. In less than 5 minutes, I'm just going to go over few or last minute issues. But I'll prove to you that you do critical appraisal every day. This is back in probably أيام الوطنية. I was surprised to see this question being posted by a newspaper, an electronic newspaper, and you'll tell me what the problem is with it. But this was the question that was posted by an electronic newspaper, and I apologize for those who don't speak Arabic or don't read Arabic, but let me just translate this very fast. Istifta Twitter, so survey, who deserves to be #1 singer in Kuwait? And I want you to answer this, but not based on your choice. I want you to answer what would you think the answer would be to this question, okay? Who thinks that people voted most for Awad Dukhi? Show me your hand. Who thinks that people voted yes for Abdul Karim Abdul Qadir? Or the best one for Abdul Karim Abdul Qadir? Again, I don't want to see your enthusiasm and you love Abdul Karim, but I need you to tell me what you think people would have done. Okay? And third, who do you think people have voted most for Abdullah Ruwayshid? Show me your hand. So you see that there is a majority. Most of the people voted that they thought that people have voted Abdullah Ruwayshid to be the best singer in Kuwait. And you get this all the time, right? You see a question, come on, people say that. So based on the question, you would anticipate what the answers would be. So, and why do you think that? Give me 2 reasons. So the population being asked are population who use usually smartphones. So you're talking about to the younger generation. Hello, so there is referral bias. You're asking people who, you're asking the new generation about new coffee brands. كل من أحلى هذا ولا قهوة العربية. Most of them, they didn't get exposed to قهوة عربية. Most of them got exposed to new brands of coffee. And they'd say, come on, people will say new brand. No one is going to say قهوة عربية. Or most of the people say, don't ask a question and you anticipate, you know what the answer would be. Give me another reason. When was the last time you heard حتى younger generations عوض دوخي? So there is a recall bias. There is something in the media you did not hear. Almost, it's very rare that you hear عوض دوخي on the radio, and very infrequent to hear عبد الكريم عبد القادر. But it's always عبد الرويشد على طول. So you know that there is not only the referral bias, but there is also this what we call recall bias. Oh, I heard عبد الرويشد أمس غنيت معاه مش عارف. So you'll answer Abdullah Rawashid. Not you, but you think that people would answer Abdullah Rawashid mostly. So that's why we think that this is not a fair question. So we do critical appraisal almost every day. We criticize what happens in real life. I'll give you another example and I'll close with that because we're reaching time. I'm just going to skip the non-important stuff. So a headline in one of the most prestigious newspapers in Kuwait, and I think May, I'm not sure about the date, but last year, May of last year, says 90% of Kuwaitis Kuwaiti males die before their wives. Okay, so some people say it's true because it came to, so headline in a newspaper. I think there is something wrong with it, and I don't know if you agree with me or not. So 90% of Kuwaiti males die before their wives. You always see widow females, right? But you don't see widower all the time. صح؟ اللي هو أرمل. سافر. Okay, so why do you think this is? I think there's a big problem with this statement. Why age? Has to do with age. Definitely. So you're talking about the time, let's say that people usually die around the age of 75. Hello? What would be the age difference between a wife and a husband? 5 years, sometimes 10 years. صح? So the husband, poor husband, always reach 75 before his wife. This is in our culture. صح ولا لا؟ in most cases. Some of us we have very comparable. Some of us, unfortunately, the wives will have significant diseases. They pass away earlier. But in the usual cases, you'll have a husband and a wife, 30 years and 25 years, let's say. This would be average starting age. And then they grow up all the way, and the husband hits 75 earlier. The wife is 70 now. So the husband, let's say the average age of death would be 75, and unfortunately husband dies before the wife. So when you say 90%, this is a terrifying statement. Please don't get married for males. كذي قاعد يقولون. لأن marriage kills. This is the statement. And that's not true, at least for epidemiologists. I would say, لحظة, was it a fair game from the beginning? Are they starting in the same age? Do we have all males and females getting married at the same age? Or not? Because it's not. In our culture, we know that it's not. So, for my male colleagues, please don't get terrified. Please get married. Okay? Because Kuwait needs to be populated. So my conclusions today is that we start with the question, And as I told you, PICO is the term that you will come across very frequently during this course. And remember, finer. Choice of representative sample is very crucial. It needs to represent the participants you're investigating. And variables also are important. Surveys are fast and expensive, but not perfect because they have their own bias. And overall, the research question should be feasible and practical and should not cause misleading conclusion. Please fill the evaluations. With that, I would end my presentation, and I thank you for your attention. Appreciate it. Any questions? Thanks. Any questions? One question. Excellent question, difficult question, excellent question. I did not want to go through this, probably might be a little bit confusing, but the cohort usually does not start with the cases or the outcomes. Case control starts with the cases or outcomes. Cohort does not start with the cases. The format of the retrospective, and did not cover retrospective cohort because it's confusing and we don't see it. I've seen one in my life. A retrospective cohort. But usually with cohort, we don't start with the cases versus cases started with case control study.